We shall now go on to Dr. SWATI UPADHYAYA, who is a medical consultant glaucoma services from Arvind Eye Care Systems from Pondicherry. And I'm sure she's going to do great justice to her talk on preferred practice guidelines, universal safe surgery system for trabeculectomy in glaucoma patients.
Thank you, ma'am. Thank you, AIOS. And I am feeling so honored to be speaking in front of so many glaucoma legends, I should say. So if I do any mistake, please forgive me.
Oh, wow.
So I'll be talking on preferred practice guidelines, a universal safe surgery system for trabeculectomy in glaucoma management. So when do we do a trab? The decision is based on magnitude and duration of pressure elevation, the extent and progression of visual field damage, the extent of damage to the ONH, and patient's own sense of visual function and course of the contralateral eye, and the general health and life expectancy of the patient. So Peng Ho has given very good safe trap technique. So it says that you should have a large treatment area, you should have a posteriorly directed flow of aqueous, you should have tight adjustable sutures, large scleral flap and not cut to the limbus, which is very, very important, and a single scleral punch sclerostomy. So I'll take you through all these one by one. So previously we used to do bridle suture, and when we do a trap with SICS with IOL implantation, we take a bridle suture which should be short and crisp bite of the superior rectus, and you should avoid taking a large area of the conjunctiva, and should be done under direct visualization through the microscope, as it can cause buttonholing of the conjunctiva and very rarely perforation. But now we have switched on to corneal traction suture, which is because it is more safer, it is less damaging to the conjunctiva. You can either take a superior traction suture, or you can take an inferior traction suture. If you have a deep bite, then you can have an inadvertent AC entry, which can lead to infection. If you have a very superficial bite, you can have cheese wiring of the cornea. So it should be just in the center, or you should have with practice, you should go only half thickness of the stroma. Then comes peritomy. Use as much as possible non-traumatic sutures or non-tooth forceps for the conjunctival handling in trab, and it should be just needed conjunctival dissection. If you should not open up the whole 10 o'clock to 2 o'clock conjunctiva if you are doing a phaco trab to inside. Because if you are doing a trab SICS also, your minimum optic size will be 6.5. So just open around 6.5 to 7 millimeters of the conjunctiva. We normally favor fornix space flap because it prevents the ring of steel formation. Conjunctiva should be handled as gently as possible, and you should do a sufficient backward dissection to make scleral pockets for the MMC sponges to be put. Excessive dissection will lead to a large bleb, or if scarred and failed, then one may find difficult to perform a repeat trabeculectomy. Cautery should be just adequate to cauterize all the bleeders which might come in your way when you are doing a scleral flap dissection. Excessive cautery can lead to shrinkage of the sclera, and later reapproximation of the scleral flap might be difficult. We normally use a unipolar cautery or a pencil or a lipstick cautery. MMC application and wash is very, very important. So this is avoided in patients with myopia, in patients with normal tension glaucoma, and when you have an overfiltration in the other eye, you can still use a lesser concentration of MMC. So normally we use 0.02% MMC. Duration is for 2 minutes. So this is placing sponges, merosal sponges under the conjunctiva, and it is being pushed into the scleral pockets the conjunctival pockets we had made during conjunctival dissection. You can also use MMC injection, which can be 0.1 ml of MMC and plus 0.1 ml of lignocaine. Scleral flap dissection, we normally use 4x4 or 4x3 millimeter flap size. The base is 4 millimeters and the maximum height is like 4 millimeters. We are not going up to the limbus, as you can see in the video. We start at the blue zone, so that blue zone 1 millimeter area is still there, and it prevents leakage from the sides of the edges. So we should avoid going at the limbus, totally towards the limbus, leave 1 millimeter gap. Then the thickness of the flap should be 1/3 or to half of the thickness of the sclera. And if you can see, if you're having a thick flap, how will we identify? We will see the underlying brownish pigmentation of the ciliary body. So we should change our plane and come to a more superior plane. Attempt should be made to avoid a scleral flap of attempt should be made to obtain a scleral flap of equal thickness throughout. It should not be a ragged flap. You should check the blade, 50 number blade, so that it should be sharp. You should not have ragged incisions and ragged cores when you make the flap, and handle with non-tooth or serrated forceps. make a side port incision, it should be very guarded, more so in primary or angle closure glaucoma cases. We should not do a sudden decompression of the anterior chamber, because then it might lead to aqueous misdirection later in post-operative period. We normally use super sharp blade or a 15 gauge side port knife, and blade should be parallel to the iris and enter only half length of the blade. Then comes the AC entry and inner sclerostomy. We use a keratome, and we do not use the whole thickness of the whole length of the keratome. We just go half triangle and then come out, so that it is a very controlled AC entry. This is a Kelly's Descemet's membrane punch which we use. If you don't have a Kelly's Descemet's membrane punch, you can use a 11 number blade also, and make a small punch. It is usually available in 1 millimeter and 0.75 millimeters also. So if you have a normal tension glaucoma, use a smaller size Kelly's punch. It should be held vertically to avoid any shelving of the tissue, and you should not keep an angulation or at the side, because it might lead to Descemet's membrane detachment. Finally, we come to iridectomy. It should be a broad basal iridectomy wider than the sclerostomy wound. It will prevent iris incarceration in the sclerostomy wound and will prevent pupillary block. Conjunctival closure, it should be watertight so that you don't have any leakage. And fornix based flap, we use 2 wing sutures or mattress sutures, and we anchor the first suture toward the episclera. And after that, we can either take continuous, as was shown earlier, or we can take interrupted. So we usually do interrupted. We anchor at both the sides. Lastly, AC deformation. We should check whether the bleb is forming. Sometimes bleb don't form on the table, but it doesn't matter. You should just form the AC tight, so that you have a good margin and the patient do not have hypotonia in the first postoperative period. If you want to check, you can use 2% fluorescein or betadine eye drops to do serials on table. Thank you.